Thank you for the organizers for inviting me to speak in this esteemed online webinar on heart failure, guideline-directed medical therapy titration. Of course, heart failure is a very common disease. Now we see it in the worldwide population, and there have been many advancements in the treatment of heart failure. I will focus, of course, here on the medications, since I'm coming from pharmacy background. Yes. So basically, I will focus on the guideline-directed medical therapy, the most evidence-based medical therapy we have, and I will focus on 3 classes only. Of course, the classes are very long. If I want to focus on all of them, which may exceed the time allocated for my session, I will focus on 3 common classes. We see them, during the management of heart failure patients. And I will focus mainly on the heart failure with reduced ejection fraction. Okay. So the objective of my session is to, given a patient with a chronic heart failure, it will be case-based approach. We will devise an appropriate pharmacologic therapeutic plan with an emphasis on guideline-directed medical therapy. And also, along with the guideline-directed medical therapy, we will also propose a titration plan and monitoring for the safety and efficacy of those medications. I have nothing to disclose. I will start with this case. Actually, JS is a 55 years old woman with trastuzumab-induced cardiomyopathy, resulting, we know trastuzumab is one of the oncology chemotherapeutic agent, cancer, that one of its main side effects is cardiomyopathy that resulted in valvular damage and actually heart failure. So we see a lot in the practice, heart failure caused by this medication. So the ejection fraction is 35%. He continues to have, of course, below 40% is, reduced ejection fraction. She continues to have dyspnea and fatigue on exertion. New York Heart Association class 3. So it's a bit advanced. Although she is on these medications, the lisinopril 20 milligram daily, furosemide 40 milligram twice daily, carvedilol 12.5 milligram twice daily, all of them are oral, spironolactone 25 milligram per day, digoxin 0.125 milligram per day. So she is on these medications chronically, but still she is on class 3 and she continues to have symptoms on exertion, on exercise. She has been stable on these doses for the past month. Her most recent lab results are normal sodium, normal potassium, as you can see, normal chloride also. BUN is also normal, along with normal renal function, serum creatinine, normal glucose, calcium, phosphorus, magnesium, all of them are normal. And digoxin is 0.9, which is on the upper limit of the normal range, because we know digoxin is narrow therapeutic index, so we need to do therapeutic drug monitoring for its levels, whether we use it in heart failure or we use it in AFib. Her vital signs include blood pressure of 112/70, heart rate of 68 beats per minute. So the lung examination seems clear. So there is no really, congestion in this case. So in this case, based on this patient given data, what would be the best that approach that will maximize the management of her heart failure with reduced ejection fraction? Will you increase the digoxin to 0.25 daily? Will you increase the lisinopril to 40 milligram daily? Will you increase spironolactone to 40 milligram daily? Or will you increase carvedilol to 25 milligram twice daily? I would like to stop here for a few seconds and check our esteemed colleagues online. What would you do? Just, as a survey here, and then we would see the right answer after we finish this chapter. Can you please type maybe in the chat box? From your daily practice, your experience, what would you do to this patient? I don't yet see any message in the chat box. Okay, we will go and proceed, and we will see the right answer as we proceed forward. Okay, so we will start actually with heart failure and beta blockers, the first class we will talk about. So basically, you know, these are the stages on heart failure. And per stage, we have recommended therapy, whether pharmacologic or non-pharmacologic. When we say non-pharmacologic, of course, we're talking about devices, we're talking about surgery, you know, LVAD, whatever. This table is telling us that we have stage A. Stage A, we don't have yet symptoms of heart failure, and we don't have any structural heart disease, but we have some risk factors, and we don't even have remodeling of the ventricle, of the heart. But we have risk factor like long-standing hypertension, atherosclerotic disease, diabetes, obesity, metabolic syndrome, patients using cardiotoxins, right? Having family history of cardiomyopathy. Again, we don't have yet any disease to the heart, and we don't have any symptoms, but we have risk factors. So what should we do here? Our goals of therapy is to have a healthy lifestyle for the heart, prevent any vascular or coronary heart disease or MI, and treat the comorbidities. And you treat them, of course, for whatever is needed. You have coronary artery disease, you treat with statins. You have diabetes, you also put statins and you put antidiabetic medications. You have hypertension, you put ACE inhibitor ARB. So you treat the comorbidities to prevent any heart injury. But moving now to stage B. Stage B actually is, again, we don't have yet symptoms, we don't have structural heart disease, but we started having MI, we started having some remodeling, some hypertrophy of the left ventricle, etc. And the ejection fraction started to reduce. So here is stage B. Here in stage B, we start to include what the medical therapy. So here, our goals of therapy is to prevent heart failure symptoms and prevent further remodeling, because as I told you, remodeling happened. We want to prevent further remodeling that will eventually lead to the symptoms and deterioration in the lung and the heart function. So we will start the patient on ACE inhibitor, ARB, or ARNI, angiotensin receptor neprilysin inhibitor, unless it's contraindicated. We will speak about this later. We will also initiate beta blocker. Okay, we will also initiate beta blocker. In selected patients, we may go for internal cardiac defibrillator or revascularization. We start the pharmacotherapy in stage B when the ejection fraction is below 40%. Okay, how about when I start to see symptoms and when there is structural heart disease? What do we do? Again, we start to go for the full guideline-directed medical therapy. So here we go for diuretic if we have fluid retention. Beta blocker should be there, ARNI should be there, SGLT2 inhibitors for everyone, aldosterone when they are optimized on beta blocker, ARNI, SGLT2 inhibitor, and they are still symptomatic, we can add aldosterone antagonists like spironolactone or eplerenone. Again, in selected patients, we can go for CRT, cardiac resynchronization therapy, ICD, and revascularization. We may use, hydroxyl nitrate, especially in African American, It shows a very good mortality benefit. Digoxin, not for mortality, for symptoms. Ivabradine for hospitalization and symptoms, but not for mortality. But hydralazine nitrate mortality, SGL2 mortality benefit, ARNI mortality, aldosterone mortality, beta blocker mortality, diuretics, not for mortality, for symptoms only. Okay? When we reach stage D, that means here we are very advanced. Here, I am having heart failure symptoms even when I am resting. Here, I am visiting the hospital a lot for hospitalizations, heart failure exacerbations. So these patients will no longer benefit from these guideline-directed medical therapy. These patients will be on chronic inotrope IV medications at home probably, or in the hospital. They will need transplant later on. They will need, palliative care, hospice, etc., and advanced care measure, maybe left ventricular assisted device, LVAD, whatever. So we saw now where the guideline-directed medical therapy goes. So focusing on beta blocker, we know that it decreases mortality. That's we said it has survival benefit by 35% relative risk reduction. It decreases hospitalization by 25% relative risk reduction. It improves the symptoms also, and it improves the clinical status. Why? Because it increases left ventricular ejection fraction. What about the recommended agents? Okay, we know that the 3 approved agents in the guideline are carvedilol, sustained release metoprolol, succinate, and bisoprolol. These are the one approved. Carvedilol, it provides additional alpha-1 blockade. So why carvedilol is preferred even, although all of them are approved, but carvedilol has additional benefit, which is further decreasing in systemic vascular resistance, which is upper load. This will relieve the heart as well. Also, it will result in greater reduction in blood pressure. Again, the less blood pressure, the less burden on the heart, which is already diseased, failing. Bisoprolol is the most cardioselective. We always start low and go slow. So we start low in the dose and we double the dose every 2 weeks, or slower if needed, depending on the patient tolerability. And we aim to achieve the target dose in 8 to 12 weeks. So don't rush to go to the target dose. 2 months, 3 months is fine to reach the target dose of beta blocker. So what about some side effects? So when you abruptly discontinue beta blocker, it can precipitate clinical deterioration, it can precipitate heart failure, it can precipitate MI. So always, if you want to discontinue for any reason, severe bradycardia or whatever, gradually. Like you started it gradually, discontinue it gradually, not abruptly. It's very important to tell the patient that improvement in the symptoms will not be seen until several months, 3-4 months. Okay, so they will not expect immediate benefit or a clinical symptom improvement. It should be considered even in patients with reactive airway disease or asymptomatic bradycardia. Imagine, even with reactive airway disease, asthma, still we can give it because they are selective. So we can give it, or those who have bradycardia but asymptomatic, still we can give it because it's very beneficial. Remember that it is dose dependent. So higher doses of beta blocker are associated with a greater reduction in the mortality. So the mortality, the survival benefit is dose dependent. And it's the only class among guideline-directed medical therapy that is dose dependent. So the higher the dose, the better survival outcome. Okay, keep that in mind as well. And also, initial dose, this is what I told you. We start with low and we go slowly over 2 to 3 months. Okay, so we start with 1.25. Imagine very tiny dose of bisoprolol, then we reach 10. We start with 3.1 to 125 BID, we reach 50 BID, etc. These are the 3, as we said, approved beta blocker. So what do we monitor? Of course, blood pressure, because it can lead to hypotension, heart rate can lead to bradycardia, symptoms of hypotension also. When you titrate slowly, that's the reason when you titrate slowly, because when you titrate slowly, less likely they will experience these symptoms. If these symptoms appear, you lower the dose by 50%. But if it's only hypotension, you will lower the other agents the patient is receiving, like ACE inhibitor or ARB or ARNI, okay, before lowering this. Why? Because hypotension can be resolved when you lower the other doses, and because the other classes is not dose dependent. Yani when you decrease the dose, mortality benefit will still the same. But for beta blocker, when you decrease the dose, mortality benefit will decrease with it. So always try to keep decreasing the dose in beta blocker, last resort. Only if you have both hypotension and bradycardia, severe bradycardia, the symptomatic. It can also lead to edema and fluid retention. If that happens, you can increase the diuretic dose. It can lead to fatigue or weakness. So it will resolve spontaneously in several weeks. So it's very important that we also counsel the patients on these symptoms, that, for them to have proper, if you want, expectations of the medication. So again, going back here, what should we do in this case? After we have seen this, of course, we should increase carvedilol to 25 milligram twice daily. That's the correct answer. Why? Because increasing digoxin will not help, okay? Because we said it's not dose dependent and it's only for symptoms, and the level is already high. Yani it's on the upper border, 0.9. There is no need to increase digoxin. You will end up in toxicity. It's not a therapeutic index. Increasing lisinopril will not help because it's not dose-dependent mortality. Increasing spironolactone, again, it will not help because there is no reason to do it. The potassium is normal, and there is no mortality benefit with increasing the dose. The only mortality benefit is carvedilol. So he was on 12.5, okay, BID. Now he will become 25 twice daily, and he was on this for a month. So we can safely, we said we can double the dose every 2 weeks. So we can safely do it now. We have another case, a 62-year-old white man with an MI 3 years ago, hypertension, arthritis, hypothyroidism, type 2 diabetes, controlled on the diet only without medication, heart failure with reduced ejection fraction, 25%. His medication include aspirin for his MI 3 years ago, simvastatin for his MI, also lisinopril for post-MI, and because of HFrEF, metoprolol for before heart failure, furosemide for heart failure, spironolactone for heart failure, acetaminophen for osteoarthritis, and levothyroxine for hypothyroidism. Of course, metoprolol will also, and lisinopril will also serve for hypertension. So he has no known drug allergies. He has high blood pressure, 155/90, normal heart rate. He weighs 100 kilogram. He has normal potassium, elevated serum creatinine, normal thyroid function, and he is considered an EHA class 3, functional class 3. So he heard about ARNI. ARNI is angiotensin receptor, which is blocker, which is valsartan, and neprilysin inhibitor, which is sacubitril. What would be considered now best before initiating sacubitril valsartan? So basically, would you decrease the dose of metoprolol to minimize the hypotension? Would you discontinue lisinopril at least 36 hours before beginning sacubitril valsartan? Would you obtain BMP before beginning sacubitril valsartan? Or would you increase furosemide to 100 milligram? He was taking 80. Would you increase it to 100 to minimize fluid retention before you start sacubitril valsartan? So let's see. And we have another question. When you will start sacubitril valsartan, what dose will you go for? Is it 12, 24, 26 BID, 49, 51 BID, 97, 103 BID, or 12, 12.5 BID? So which one will you go for? So let's see now how we will answer this. So heart failure and ARNI. So again, revisiting this stage, we said that ARNI, we started with stage B. We can go for that, and stage C as well. Remember, ARNI, we go in NIHA class 2 to 3. They are indicated in class 2 to 3. So look here. So this is how we go by stages for HFrEF stages, C and D. So if you look here, actually, you will find that if we have heart failure with reduced ejection fraction less than 40%, and we have class 2 to 3, you can start ARNI even before you start ACE inhibitor or ARB. Now they are more recommended, ARNI more than ACE inhibitor or ARB. They can replace them. Of course, they have to be on beta blocker, SGLT2 inhibitor, diuretics as needed, MRA, again, when they are not responding to the other agents. If beyond this, they still have persistent HFrEF, then if they are African American or African in general, we can go for hydralazine nitrate, as we said. It's best in this population. Or we can go for non-pharmacologic treatment, then later transplant. Later, when we go to stage 4, 5, or 6, here, mostly medication will not benefit. So here we need to go to non-pharmacologic treatment, as we said in this case. So in the guidelines, they mention, American Heart Association, that in patients with previous or current symptoms of chronic HFrEF, we can use ACE inhibitor only when the use of ARNI is not feasible. So, in other words, if your patient is already on ACE inhibitor or ARB, replace them with ARNI. So, discontinue ACE inhibitor or ARB and add ARNI, okay? Because it has better benefits on morbidity and mortality. Okay? And they have very high, economic value, so it's worth it in pharmacoeconomic perspective. So when you look here, actually, about the clinical purpose about ARNI, now what dose you will start? Let's say your patient was not taking any ACE inhibitor or ARB. You can start with the lowest dose, okay, 25, 26 twice daily. Or if the patient has renal impairment, eGFR less than 30 ml per minute, you start also with low dose, 25 to 26, over 26, so total 50, okay? Because we have two components, so we have 2 milligram here, okay? Or the patient has moderate hepatic impairment, also you start with this low dose, okay? What if the patient was already on ACE inhibitor or ARB? Again, if he was on ACE inhibitor equivalent to more than 10 milligrams of enalapril, okay, then you start with higher dose because you anticipate they need higher dose of ARNI because they were already on high dose. If they were on lower doses, like less than 10 milligrams of enalapril or lisinopril or ramipril, you go with the lower dose. Okay, but always we stop ACE inhibitor 36 hours before starting ARNI, sacubitril/valsartan, and then we double the dose every 2 to 4 weeks. Okay, the maximum target dose is 200 milligram BID. Okay, ARB, same thing. If they were on high dose, like more than 160 milligram valsartan or equivalent, you start with high dose, like 100 BID. If they were on lower doses, you start with lower dose. But the difference here is you don't need to stop for 36 hours, like ACE inhibitor. If the patient was on ARB, you just stop the ARB and the next dose, okay? Let's say he was taking this dose once daily or BID, the next dose will be the ARNI. You don't need to wait 36 hours. And the reason here is that because ACE inhibitor can cause angioedema, and ARNI also, specifically sacubitril, can cause angioedema. So that's why you need to separate by 36 hours. Okay. whereas it's not the case for ARB, because ARB is much less associated with angioedema. Bioavailability of valsartan in sacubitril valsartan is 40% greater than that of valsartan alone, and this is the equivalent dose. So if the patient was on this of sacubitril valsartan, this is equivalent to this, and this is equivalent to this daily. Okay. Just to tell you here that why in this combination we give lower doses of valsartan, because it has higher bioavailability when it's combined with sacubitril than valsartan alone. Again, you monitor for hypotension, hyperkalemia, like you monitor with ARB. You monitor for cough, elevated serum creatinine. Again, cough is due to sacubitril. Angioedema is due to sacubitril also. Okay. ARB can cause hyperkalemia, can cause hypotension, although it's less than, hyperkalemia less than the ACE inhibitor, or less inhibitor, and symptomatic hypotension is more with ARNI. Something extremely important, when you want to monitor ARNI efficacy, you don't monitor BNP, because BNP will be elevated after you initiate sacubitril valsartan. So what do you monitor? You monitor actually NT-proBNP, which is more specific. It's a precursor for BNP. Okay, it's a precursor for BNP. So sacubitril will increase BNP, so it will be falsely elevated. So don't monitor it. You will say, oh, so I initiated sacubitril valsartan and BNP got elevated. No, it's because of neprilysin inhibitor, because of sacubitril. But the proper measurement of efficacy is to monitor NT-proBNP. This is the one that will be decreased when you start ARNI. So in that case, what should we start here? Actually, we should start sacubitril valsartan and discontinue lisinopril 36 hours. Remember why? Because the patient was on ACE inhibitor, so we need to discontinue 36 hours to prevent the risk of angioedema. No need to decrease the dose of metoprolol. Again, the patient does not have bradycardia, and on the contrary, the patient has hypertension. So it's even good to start sacubitril valsartan, which will reduce blood pressure. Obtain baseline BNP, as we said, no, because BNP will be elevated with sacubitril valsartan initially. So we should obtain baseline what? NT-proBNP, not BNP, with sacubitril valsartan. Increase furosemide, there is no need, because there will be no fluid retention here, and the patient does not complain of any congestion. So the correct answer, as we said, stop at least 36 hours there. So which dose will you go with? Actually, 49/51. Why? Simply because the patient was on ACE inhibitor and was on a higher dose of ACE. It was more than 10 milligram enalapril or its equivalent dose. Okay, I have the last case and the last class I will speak about, which is Ivabradine. So LS is an 87-year-old woman referred to second opinion after 4 hospitalizations. So it is having multiple hospitalization for heart failure in the past 6 months, which is a lot. Long history of hypertension. She denies having angina or coronary disease. She has functional class 3 as well. Medications include 20 milligram daily lisinopril, 0.125 milligram digoxin, carvedilol 50 twice daily. So again, she is on the maximum beta blocker, spironolactone 25, furosemide 20 milligram daily. So she's complaining of what? Of multiple hospitalizations. Vital signs, normal blood pressure, normal heart rate, even more than 70 heart rate, serum creatinine a little bit elevated, borderline potassium, echo revealed ejection fraction less than 40%, which is 38%. We have normal ECG as well. So what would be your most appropriate recommendation? Would you add metolazone, which is thiazide-like diuretic? Would you add Ivabradine? Would you consider cardiac resynchronization therapy, CRT, non-pharmacologic? Would you increase carvedilol? Let's see. Ivabradine is very important in reducing hospitalization. Remember, symptoms and hospitalization. And when? So there are certain criteria to add Ivabradine in heart failure management. These criteria are symptomatic patient, 2 or 3, like our patient in the last case, stable, okay, and ejection fraction of 35% or less, receiving guideline-directed medical therapy, including beta blocker at the maximum tolerated dose. And the patient was receiving carfentanil 50 daily, BID, sorry, 50 BID. And remember, that was the maximum patient can go with in carfentanil. So he was on the maximum tolerated dose. And the patient should be on a heart rate of more than 70 beats per minute and normal sinus rhythm. Again, the patient should be on beta blocker maximum tolerated doses, should be NIHA class 2 or 3, ejection fraction almost 35 or less, and heart rate more than 70, and at rest, and normal sinus rhythm. Okay? If the patient has AFib, you cannot start Ivabradine at fibrillation. So we start with 5 twice daily. We take it with food because of increased bioavailability. For patients who have conduction defects, bradycardia, we can go with lower doses because it can lead to bradycardia. And let's say you started with 2.5 twice daily or 5 twice daily, whatever. It's always taken with food, depending on the patient, either 2.5 twice daily or 5 milligram twice daily. So when you start, then you assess. After a week or 2, you check heart rate. Are they still more than 60? Then you increase the dose by 2.5 BID every week until you reach 7.5 BID. If they are between 50 to 60, then maintain the. This is our target: 50 to 60. 50 to 60, our target. If it's less than 50, then decrease the dose by 2.5 BID. If the current dose is 2.5 BID, then discontinue. Okay. What do you monitor for Ivabradine? Again, monitor heart rate. The main thing about it is, again, heart. So 2 weeks after initiation of therapy, and then periodically thereafter. Contraindicated in acute decompensated heart failure. Blood pressure is a 90/50. Six sinus syndrome. Second or third degree heart block. Heart rate less than 60 beats per minute. Severe hepatic impairment, pacemaker dependent, and avoided with CYP3A4 inhibitor inducer because it can lead to interaction because it's metabolized in CYP3A4. So what would be the most appropriate? Of course, adding Ivabradine here. Why? Because the patient already on maximally tolerated beta blocker. The patient heart rate was 74. He was NIHA class 3. And he was not in AFib. ECG showed no atrial fibrillation. The last thing I want to leave you with is a brief, overview of heart failure with preserved ejection fraction. Again, heart failure with preserved ejection fraction, it's similar to the one with reduced ejection fraction. So here the ejection fraction is more than 50%. What do you give? Of course, you can give the same management as you give for HFpEF with reduced. The only difference is that beta blocker is not approved here and does not have any beneficial. But all others you can give. So again, same management as HFrEF, but without beta blocker. And this, summary shows you the 4 pillars, and again, without beta blockers. In pregnancy, what would you do? Of course, ACE inhibitor, ARB, ARNI, MRA, spironolactone, SGLT2 inhibitor, Ivabradine, very sigwat. We don't use them in pregnancy, contraindicated. So what if you have a pregnant woman with heart failure? Only you can use beta blocker. And when she delivers the baby, she can resume back all the other medications. Or we can give hydralazine nitrate also, and adjust the diuretic. Also, we can give diuretic, also adjust the diuretic dose to minimize the risk of placental hypoperfusion because it's diuretic. What about breastfeeding? Again, no, we can give ACE inhibitor, we can give beta blocker, we can give diuretic. Okay, but you should monitor.